Ryan Stanton here with ACEP Frontline, and joined by a guest we have often. It tends to be around PIM, but we've also done some of the pediatric readiness with you as well, and then various other topics. Actually, you were one of my first that during COVID that I interviewed from the inside of a car. You weren't in the car with me, but it was I was on going to a race and doing the interview, and
yeah, I do remember that. Yeah, that's funny.
I was in the car, and the acoustics in cars are actually pretty good as long as you don't have the air conditioning on too high. But Dr. Marianne Gausche-Hill, thank you so much for being with us and for everything you've done for the PIM assembly and getting the continued growth and success through the Accelerate Conference. So appreciate that.
Did you know this is the 20th anniversary
of
the PIM Assembly?
All right, so which one would I have gone to?
2006 was the first. It was in Washington, D.C.
And then I think 08 was the first. Was 08 the first one I went to? I think so. Because that would have been Orlando.
Orlando, yeah.
It would have been Orlando.
And that was a really good one.
I loved that one.
That was really fun.
My wife, Med Peds, she was there with me. That was my first experience where talking with Chris Amato, and then Sean Fox comes up, and we actually got I think it's actually happened multiple times where he has interrupted one of the podcasts with Amato just to
do that.
just to be PIM. Just to be PIM.
Yeah.
All right, so here, and we like the format and everything, and we'll talk about next year by the time we wrap up. But kind of dive into some of the hard-hitting things that you talked about here this year in San Diego.
Yeah. Okay. I'm doing total of 4 talks. Okay, but I'll do some take-homes from each one maybe because I think they each have a message, and things that can be cross-cutting and important for emergency physicians. One has to do with pediatric chest pain. I did this morning, and really the issue here is finding the cardiac, cases for pediatric chest pain. It's difficult. So how can you do that? Because it's rare. They say it's about 1%. I think it's way less than that.
Yeah, I agree.
And so the issue is, how do you do that? Well, I think one of the things that emergency physicians tend to do, not everyone, of course, but tend to do, is they assume that children that look well are well and always have been well. And so past medical history is critical, okay? So as an example, if they've had congenital heart disease, if they've had Kawasaki's when they were 2 years old and they're now 10 and they come in with chest pain, that's a whole different algorithm than those who come in with no previous history and chest pain. And the reason why is that continues to put you at risk, Kawasaki's, congenital heart disease, for MI at a young age. And, I think the youngest kid that I've seen with an MI is around 14 years old. But you have to, if you never ask those questions, you may opt to approach that patient very differently. The other thing that is critically important to ask for kids who come in with chest pain, altered mental status, or some otherwise ill-defined sick kid, family history. Family things run in families, right? So as an example, understanding that there's sudden death in the family is very helpful. And at what age? So the siblings who die young, you're thinking inborn error, but it could also be prolonged QT. And then the other thing is, HOCM or hypertrophic cardiomyopathy, that also runs in families. Brugada, runs in families. So things like that, it is important to know that there's been sudden death or a death in the family, or someone who has been critically ill and hospitalized. I'm not talking about, granny at age 90, but those at a young age that come in that need to be hospitalized. So I think asking those critical questions, okay, so those 2 critical questions, and listening to their heart making sure they don't have a scar on their chest wall, and no edema, no big liver, you're done. They don't have congenital heart disease. They don't have a cardiac cause. I mean, it's really far less likely. So I think that's really it. Otherwise, you approach them, it could be respiratory, it could be GI, right? It could be psychogenic. The other thing I brought up on Pete's chest pain was psychogenic, is kids who come in and they have ADHD, they're on, Adderall, or they're on an antidepressant like Lexapro or something else. Then you need to explore that further, because their chest pain could be psychogenic, and what it is, meaning that they could be somaticizing. Mm-hmm. They're really depressed. They're doing terrible in school, they're getting bullied, or what have you that's happening to them. And they want somebody to know, but they don't know how to say it, so they come in with chest pain. So I think getting, are they on meds, past medical history and family history really helps target things, and then otherwise you approach it like you would, other conditions. Now, what do guidelines or published algorithms, what do they say? Well, everybody says get an EKG. Mm-hmm. Everyone. So you just get one, all right? We get it in the pre-hospital setting, we get it in the ED. Or you get syncope, you just get it, because then you take that thing off the table, right? The one that's a little controversial is chest x-ray. A lot of them say you don't need to do it. I find that, if they're absolutely normal EKG, no other signs or symptoms, nothing else that would lead you to a respiratory cause. They never had asthma, they never took albuterol in their life. You could probably forgo the chest x-ray, but I find the chest x-ray I have a fairly low threshold because the risk is so low and there's potential benefit, like a kid who comes in, non-diagnosed. I had a 15-year-old undiagnosed, right, asthma, but said, he's been treated a couple times with albuterol, but he's never been on steroids, but he comes in, he's got this ill-defined mid-chest pain. Anyway, I get a chest x-ray and he has pneumomediastinum. So at least I have an answer, I can talk to him, am I going to admit him? Probably not, but my whole approach to him in terms of risk and coming back is going to change. So that's kind of the bottom line for that one.
And then I think your questions are important. The reminder, not a pediatric patient, but a 34-year-old who came in with just some burning substernal chest discomfort. But it was exactly that situation where the shirt comes off to put him on the gown and he's got a zipper.
Yeah, he's got a
and
zipper.
He's already had cabbage, at this point. And it absolutely changes the approach. But it is that index of suspicion, because it becomes even harder in a population where you assume they're healthy. Kids aren't supposed to be sick. And so you don't expect in most settings that a kid comes in with chest pain or shortness of breath. You think, it's just viral, it's just, got hit with a baseball, whatever the thing could be, you're already anchoring yourself to a non-critical diagnosis or an outcome. Of course, coming in sick, not sick. And so I think it's even harder when I go in to see a 55-year-old obese male who has chest pain. I'm already thinking about acute coronary syndrome. And so I think that the challenge is with pediatrics is to continue, and I think I have to teach our EMS people this all the time, because they go see these patients they've seen, the frequent flyers, and the assumption is nothing's wrong. Nothing big is wrong. Is that continuing to have that index of suspicion, as Dr. Fox mentioned coming in, that during viral syndrome, it's easy to, cold, and now, but wait, I need to at least take the time, the questions, the interest to say, is there somebody else that puts them in that higher risk category?
Yeah, are you the myocarditis one instead of just the URI? I mean, the other thing to think about, when you ask about family, would be if somebody has pleuritic chest pain or they come in, I'll give you a great example in a second, but anybody have a PE, on blood thinners for blood clots? And as an example, my nephew okay, who is like 19 years old, came in with pleuritic chest pain. I happen to know that his father is protein S and is on Eliquis. So he goes in, they get an EKG, they get a chest x-ray, and they send him home. And they call me, and I go, oh, my God. You know? Anyway, he went back. He had a PE, right? But they never even, that never entered their mind, and they never asked even, is there a family member who is ill, especially with pleuritic chest pain. So I think it's just, you know, it's so easy to ask, and then you kind of take it off the table, which is nice. If you don't ask, then you're going to miss.
Well, and if you see any of my kids, because my father-in-law, he's had DVTs and PEs. My wife has had DVTs. So with my daughter just having a knee surgery, that was one of our main focuses. Was, and then I've had my grandfather passed away from a PE associated after a hip surgery, even though we don't have any of the bloodborne related stuff, but there is on that side of the family. And so that is important, that atypical things in low occurrence, high risk, that should not be a huge consideration in the majority of the population, but is very important in a small part of the population that could be just a simple, small question.
Small question. And if they have any serious medical problems. Now, I will say that, and we've all experienced this, you know, even asking a patient, do you have any medical problems? Oh, no. Are you on any medicines? No. And you get the blood sugar back, and it's 350, and they go, oh, yeah, I didn't take my insulin this morning. You know, I mean, there's that, too, you know. So,
I get that. Yeah, I don't have any medical problems. Well, then why are you on Brilinta?
Yeah.
Okay. Oh, yeah. I assume that was fixed. No, it's not fixed. It's temporized for the moment. All right.
That's cute. Okay.
All right, so number 2, you get a mitigating anxiety and pain.
Oh, yeah.
Procedural sedation, some of those things. This has become a big topic because I think, you know, pediatric sedations in the emergency department, it's interesting because with me being an emergency department that has a relatively small pediatric population and a ton of people in their 80s, 90s, and, you know, tickling the 100.
Yeah.
You know, I've become more nervous about some of those sedations, you know, in a 95-year-old than with pediatrics, because, you know, from that standpoint. So talk about some of that mitigating anxiety and pain for procedural sedations.
Well, first of all, you know, children do experience pain from in utero on. I think we're all aware of that, and that there are some downstream consequences of not treating pain, such as healthcare aversion, right? They don't want to come to and see anyone because they're scared, because they're going to, you know, potentially have a painful procedure. So I think mitigating that through, you can do pharmacologic and non-pharmacologic. The non-pharmacologic are really simple. I swear to God, the iPhone has been the biggest revolution in my world because, you know, you get a kid on, you know, I don't know, Teletubbies, that's old hat
That'd
now.
Be a little
Old,
insert your new show here.
Yeah.
No matter what year. Just insert it.
Yeah, I know, exactly. Right, the latest thing, my daughter loves, she liked Dino Ranch as an example, my granddaughter, not daughter, granddaughter. And so anything like that, and they're able to watch, I mean, you can do a complex procedure and they're not flinching or moving around because they're completely distracted. You put up a little, you know, you put up the little screen, somebody's either holding it, you have the parent, so they're doing something, and then, you know, but I think the use of topical is really great. You know, the LET, and even like for sutures, doing a couple rounds of LET. The key is you don't go too long or else you're chasing your tail. So if you did it about 10 minutes apart, 3 dosings, studies have shown that in some cases you don't even need to do injectable lidocaine. Right. Although I probably would if, you know, I do a little just to make sure that they don't feel anything. But you could potentially just use LET, especially on, you know, small lacerations. So I think LET is a great tool for us. The other thing is just getting them sit still enough and how you communicate with them. I think trying to negotiate with a 3-year-old is really not a great strategy.
It won't work.
It will, yeah.
It will not work.
You can say hands down it won't work, but I do think that explaining what's going to be done and then do it. Don't explain what's going to be done, step out of the room and come back even 5 minutes later because suddenly things are a tragedy. And if they don't have time to really think about what's happening, that's fine. The other thing is if you want to give control, do you want this in your right arm or your left arm? I'm fine with that as long as those are 2 strategies you're comfortable accepting, right? And the other thing is I generally explain it's going to hurt, and I love counting. Okay, we're going to count together, and when I'm done, it's done. And that is a really useful strategy because they're looking at you in your face, and you're going 1, 2, 3, right? And that is a great it's very simple, but it works. And so some of these non-pharmacologic strategies are actually very powerful for children, even adults, frankly, putting an IV, okay, this BN, I'm going to count to 10. Now, as you know, we don't always get the IV on the first try. So, again, you could use topicals, you can use intradermal, and anytime you're going to inject, somebody tapping on the same extremity is really helpful. It's kind of the Buzzy Bee philosophy where basically your nerve fibers are dealing with 2 things at once and they can get confused. And so the bottom line is that just even tapping on an arm while the injection is happening is great, and it helps. So some of these mitigation strategies are not intranasal meds or what have you. So getting to meds, really Tylenol and ibuprofen, and you can give them together too, are great for pain control. The key is just understanding if they have pain, and there's no universal 100% pain score that's better than another at particular ages, except for in the preverbal child, they don't understand, they can't tell you 1 to 10. They also don't understand that 1 is low and 10 is high. So you can't use that. So many people use the FLAC, whether they are, grimacing, whether they are consolable, whether, that type of thing. The face grimace, with pain. And I use that in patients with poor executive functioning. Could be autistic, could be dementia. But for children, we also use it for those preverbal. Once you're around 5, you understand how to count. You also know that 1 is lower than 10, but that's all you know. And so that's why people use the Wong-Baker, but in actuality, like I said, there's no absolute on this. The key is just trying to measure, do you hurt? And you could say, do you hurt a little? And you can even do faces yourself, and the kid might say, oh, that's it. And so I think some score is reasonable. Measure the pain, and then treat it. And so the oral meds are really good. Start there. If they have a fracture dislocation, they have an open fracture, they have obviously a deformed fracture, then, I like giving that and then going to seeing how they're doing and then going to a narcotic, typically intranasal fentanyl. If I know they're going to be reduced, I'm just going to do the IV and give it to them IV because it's really good, and I know I'm going to need an IV to do the sedation. I just go straight there, I don't let them suffer. I don't go into, they're rolling around in agony. They're in pain. They're going to get a narcotic. I do find that parents sometimes get anxious. What did you give my child? I gave him fentanyl. Oh my God. The reaction. I said, it's acute pain. It's short on, short off. They're not going to become addicted from one dose in the ED. So I think you have to explain that. It's really those more with ongoing chronic pain that we tend to have more of a problem. And so the other thing for emergency physicians, so you got to assess pain to treat it. Start low, move high, unless they're in really significant pain. You don't want to leave them in 10 out of 10 pain without taking care of it pretty quickly. From a patient-centered standpoint, that is number one for patients and their families. First of all, they want you to be competent. That's number one. Number two is they want their pain taken away. So addressing pain is really important from patient-centered. So, and then there's, a bunch of stuff, dexmedetomidine, right? Nitrous it's great if you have it. Most have the 50-50. You don't want anything, higher than like 70-30, but most would do 50-50. And you have to be at least 2. You got to be able to hold the mask to your face, and then when you get too sedated, it drops away. So in case there's hypoxia associated, so we don't really use nitrous much anymore. We did for a while. I find it helpful if people are really anxious. They can breathe the nitrous, and that gives them a sense of well-being, and then you can talk to them, and then you can add other things to treat the pain. But I think just developing an armamentarium, assess pain, treat it early, have a graduated thing, and have different strategies: topical, intranasal, intramuscular, and IV. And I think, we're good to go.
All I can think about, since you mentioned the counting, is after your IM ketamine, I think we're going to count to 480 together.
Yeah, exactly.
Yeah.
And then the procedure will be over.
And then it'll be done. Even though I love it. I mean, you mentioned the LET and the topical. I had a scalp lac that needed 2 staples a couple weeks ago, and just gave the mother the job to apply the LET every so often. Because what I found is that often they'll do a dose, they'll put some LET on it in triage, and then nobody touches it for
an hour,
and it's run off, it's gone, and the kids
got
nothing
about
out of it.
30 minutes, right?
Yeah. And so giving the mother or the family member the job of just applying it every 5 to 10 minutes and then coming back and checking not only gives them something to do, but also they're probably better at getting the child compliant than we're going to be.
Yeah.
All right, so let's touch on the fever, because the fever in the special populations. So that's our potpourri. With Dr. Gausche-Hill.
Wow.
So this is interesting because we are in infection season right now. Everybody's got the flu, some good old-fashioned coronavirus going around. There's a little bit of everything right now, and I'm seeing a lot of kids that are coming in with 2 and 3 different things. But talk about the special populations a little bit with fever.
Well, let's talk about the under-immunized or not immunized.
We just got the announcement in Central Kentucky today about measles high-risk exposures because somebody went in. So
No, it's crazy. I mean, I think part of it is the population fearful after COVID of, the whole vaccine thing and whether or not vaccines really work. It turns out vaccines really work well. I mean, it's changed my entire career from polio. My cousin had polio, and I remember going with my mother and, holding her hand and getting the sugar cube and he was in an iron lung, believe it or not, and then through my whole career, seeing children come in with opisthonis from Haemophilus meningitis, it's just unbelievably amazing, the change. Anyway, so the unimmunized, this is where we started. If you've had at least one Prevnar inhib, you're going to be pretty covered. but you're still under-immunized. I mean, you're still at risk, but I think it's more in the 80% range versus, meaning you definitely have some coverage. But in someone who's never been immunized, unfortunately, you're going to be at risk. Now, a lot of people say, well, the herd, right? And that's true, but it depends on who your herd is and who you're around a lot, and also who's getting the risk of infection, right? So school age, and young children, babies, are going to be at higher risk. And so, the question is, what do you do about them? So we had this whole discussion. There's no absolute algorithm for unimmunized. But what is recommended, let's just say in the Red Book, from AAP's Red Book on infectious disease, is to screen. And we don't screen everybody. If you're immunized and you got a fever, unless there's something else going on, again, underlying comorbidity or significant exposure, let's just say to meningococcemia, we're not going to really screen after a certain age, right? The very young children we're going to screen. You're talking about the 7-day-old or the under 28-day-old, we may do screening. Again, urine and inflammatory markers now with the new AAP guidelines. But, the bottom line is when the unimmunized, what do you do? And I don't think there's a good answer. And you don't know their full exposure history. So the recommendation really is to screen and then to treat them like we used to when, 5 or 6% of the population could have occult bacteremia. We don't have that anymore. But what do you do with these people? I think the younger they are, the more likely I am to do some significant screening. If without having a UTI, again, the likelihood past a certain age, and I would say at least 2 months of age, the likelihood that they're going to have meningitis is really low because we're just not seeing it in the population anymore. It's so low. So there's unimmunized. And then other special populations you have to think about are KD, Kawasaki's disease, and, when do you pull the trigger on calling somebody, giving IVIG and aspirin? Well, you have your classic signs, the whole idea of conjunctivitis, right? The strawberry tongue, the swelling in the hands and the feet, etc., right? So you have that, and lymphadenopathy, of course. And you have classic features, 5 days fever, you need to pull the trigger. That's a different kid. You want to, ultrasound for coronary aneurysms, and you want to treat them empirically. If they're not that, but 4 days of fever and some of the symptoms, 2 or 3 of the symptoms, but not all of the symptoms, then you do some screening blood tests. And so that's going to look for, thrombocytosis, liver function abnormalities, white cells in the urine as an example. So, and then CRP, and is that elevated? And then you might screen. So fever in special populations, looking for KD is a special population. The last one that we talked about is fever neutropenia. And really, that has really transformed a lot. And the only reason I say that is they have learned that as a general rule, just monotherapy versus we used to throw everything at fever neutropenia. And the problems are that there are more complications from multiple meds than there is benefit. And so a drug that can treat, is broad spectrum, that can treat, gram-positive negatives and Pseudomonas, you can do that with like cefepime, right? Ceftaz as an example, and some of the meropenem, and those kinds of drugs, carbapenem, those can be used as monotherapy. And then you add on depending on what else you have, right? Oh, you have a port. Do you add Vanco? Do they have typhlitis? You're going to add, obviously, abdominal stuff. You might add metronidazole as an example. So with fever neutropenia, you want to look for a source. And then now what is very different is they've learned that bringing them into the hospital may not always be the best solution, right? Because then there's greater exposure and they may just get sicker. So the question is are there low-risk criteria and high-risk criteria? And there are, and I think one of the take-homes for me is any emergency physician is going to know that an ill-appearing somebody with neutropenia, they're going to treat them and admit them. Right, they're going to get blood cultures, et cetera. For those that are well appearing, then the question is you need some kind of shared decision making, and I think that would be to call their hematologist, oncologist, if you can. Sometimes you can't reach them. Sometimes that's a challenge. If they're truly well appearing, then screening, and if they're screen labs, they don't have a big white count, they don't have inflammatory markers, as an example, then you might be able to send them home, give them ceftriaxone, send them home, or put them on, or you could, there's oral cefepime as an example, or give them Ceftaz. But anyway, the bottom line is they get next day follow-up and the blood cultures are followed. So there's also short course therapy now. So I think the whole idea of fever neutropenia, first of all, it's scary. They're at high risk. There is no question compared to the general population. But there are higher risk like AML or recurrent, leukemia of any sort. They've relapsed. Some of the cancer, solid tumor can during chemo, those are also potentially at high risk. But the bottom line is if you don't know, shared discussion, always go conservative. You bring them in for a day. You try not to do it if they're truly low risk, meaning they look well, they don't have super low white cell count, and their markers are negative, you potentially could treat them and follow them daily until their blood cultures are negative. So stuff like that.
And we get a lot of those now with our adult oncology patients. They come in with fever, giving them a dose, cultures, talk to the oncologist, send them home. Because you're right. I mean, part of my discussion with a lot of my patients, especially those that come in with viral syndromes, is, we can keep you in the hospital, but you're going to be exposed to a lot more. Especially this time of year. The entire hospital is packed with COVID and flu and RSV and human metapneumovirus and norovirus and a little bit of everything for us right now. And, so that shared decision-making conversation is integral. All right, we're rounding third and heading home because we've got status epilepticus in children.
Oh, yeah. That's scary. First of all, once you seize for 5 minutes, you're pretty much in status. And so the question is, how do you treat that? Well, earlier treatment is better. Don't waste your time, getting a blood sugar. I would get one eventually, but I don't even focus on that. Don't even focus on that. You're focusing. The bottom line for seizures in kids is stop the seizure, okay? Then you start figuring everything else out, right? Now, getting a history is important. Was there trauma involved? Are there meds, like somebody's on isoniazid or something like that? Then you might have a different approach. Previous history of seizures, what's worked, what's not worked. But the bottom line is you're going to do the same thing. You're going to position their head, make sure they're monitored. You're going to either get access, or if that is even an issue, you can give intranasal meds, give intranasal midazolam, you can give IM midazolam. So, the bottom line is stop the seizure as quickly as possible. And now you're talking beyond benzos. So generally we say benzo, right? And, studies have shown that not one benzo is necessarily better than another, although I do believe that midazolam does have advantages because of the ability to give it intranasal and IM, so I think it's better absorbed. And so I do like that. So benzo, once I'm on the second benzo, I'm already drawing up a second-line agent. And really, there's 3 that I typically think about, which is valproate, which we don't use a lot anymore, levetiracetam or Keppra. I almost said ketamine, but that's another choice.
That'll work. You gotta do something.
Yeah, you gotta do something. And then fosphenytoin. And if you had to remember a number, 20 per kilo for a second-line agent, just give them 20 per kilo. Now with Keppra, we tend to go as high as 60, but I think the bottom line is if you start with 20, you're okay. Just you can add another 20 of like, what's the dosing of this? Second-line agent, all of them are 20 per kilo. You could start. Even phenobarbital, you could. And that's another potential, but we typically don't use that except for the neonatal population, but there's not a lot of great data there, as you know. And so then you, obviously you want to make sure they're well oxygenated. Typically, if you've got them in a good head position and you're, again, focus on stopping the seizure, you certainly don't want them to get hypoxic, and you can get dysregulated breathing, and they often hypoventilate during seizures. So the key thing is just good monitoring. And I typically go through my second-line agents easily before I even consider any airway management, meaning either bagging or, unless obviously they show severe hypoxemia or something like that, hypoxia, I'm not going to worry about it initially. I mean, you always worry about it, but you don't, just as long as you're monitoring them, I generally can go benzo, second-line agent, no problem. Once I get to a third agent, now you're talking about either using continuous IV, like a midazolam drip, propofol. Typically, you don't want to stick with an agent that's shown not to be effective. And so propofol or ketamine may be used. The other thing to consider really at this point, once you're an hour in, is EEG monitoring. You got to stop them. The other thing is to paralyze them. Now, the problem with that, obviously, is you don't know if they're continuing to seize. So if you're going to end up intubating, is when I think about when I'm on my third-line agents, is when I think about it, or the need to do so. You can get a venous blood gas, you can do end-tidal CO2 monitoring, and what have you, just to see where you're at to make a decision about intubation. But typically it's around the third-line agent, and it's probably about an hour in by this point. And so this is, you really need help at this point, because I think it's challenging. If you're going to paralyze them, intubate them, put them on a drip, and they're going to need an ICU. If you need to transfer them, obviously they're going to need a critical transport team, and those are tough to get. So if I have a kid that I'm going on the third-line agent, I'm already beginning to think, how am I going to get this kid to a regional center, unless you have a PICU? And, few hospitals have PICUs anymore. All
right, so you've got made it through our potpourri of talks and topics here. Talk about next year and getting people to the
Orlando?
PIM assembly. We're going back to the roots because we will be on property in Orlando, and so it's going to feel like PIM of old, January 24th through the 28th, 2027, at Disney's Coronado Springs Resort in Florida. So,
well, typically people do bring their families and have a lot of fun. And so, the great thing about it is there's great learning, and yet, your whole family can join you. And it's really a great community feel on property in Orlando. And we've been there multiple times, and people bring their families, and they just make it a real vacation, which is nice. And yet you get great learning and great, camaraderie. Can I do one more pitch?
Sure.
Remember the Pediatric Readiness Assessment. March 3rd, it's opening, and every ED in the United States should respond, because it will help you, as you know, Ryan, from multiple podcasts on this, is that there's been a real association between high readiness and mortality. And staying committed, or just understanding, it's not rocket science, you guys. It costs very little, $4 to $48 a visit, less than getting immunizations in most situations. And yet it would save literally thousands. At least the estimates are over 2,000 children would be saved if EDs in the United States would just commit to pediatric readiness, which again is not rocket science. So March 3rd, pedsready.org. Every ED in the U.S. should participate.
There you go. Appreciate it, and appreciate you coming in again. Actually, that was the topic when I was in the car at the race. We were talking about
I know it was.
The pediatric readiness.
Yeah.
And but I appreciate your time coming in. You've done a fantastic job. You and the rest of the faculty with the PIM assembly here.
Thank you.
I always love it. One that even though community emergency physician, one of the conferences I've kind of fallen in love with and adopted since 2018. So appreciate everything. As for me, you can contact me, rstanton@acep.org. rstanton@acep.org, at EverydayMed on X, and ensure that you are subscribed to the podcast on whatever platform that you enjoy. Send us 5 stars. Give us a good rating and comments to help drive more people to the channel. And until next time, I'm Dr. Ryan Stanton, and this has been some ACEP Frontline.
If you're not on the front lines, you're on the sidelines.
Cue the music.
Bow, bow, bow.
Dinger. Quiet place, all
Yeah.
alone. Da, da, da.